Now I'm going to introduce our next speaker, Dr. Bryony Insua-Summerhays. Is a senior clinical psychologist working in complex adult mental health. She completed her doctorate in clinical psychology at the University of Oxford with a focus on social cognition in complex emotional needs and neurodevelopmental conditions, together with identifying women at risk of difficulties in the parent-infant bond. She holds a post-secondary care working with a range of presentations, often in the context of early developmental trauma. Within this, she works between CBT, mentalization-based, and schema-informed models. Outside the NHS, she is undertaking training as a Jungian Analyst with the British Jungian Analytic Association. Thank you.
So thank you very much for having me today. And thank you to Dr. Guerrero for organising this conference and St. Catherine's College for hosting. It's a real pleasure to be here and to be involved in this discussion. And my hope today is to explore something of the role of empathy in psychological intervention, and particularly thinking about the process by which empathy is drawn upon within psychological therapy, as well as psychological intervention more broadly as it rests within healthcare institutions. Really, this is towards building something of an understanding of the function of empathy as a mechanism of change in itself. So, starting with what is it that makes empathy matter? So we've already heard that the word empathy was only introduced into the English language some 150 years ago by Edward Titchener, deriving it from the German Einfühlung, meaning feeling into. And whilst it was labelled at this juncture, it is somewhat core to the human condition and our capacity for relatedness. And in this sense, we see it as present within our earliest interactions, within the sort of subtle coordinative dance between parent and infant, the motor and affective mimicry that goes on within the pair. The developmental psychologist Beatrice Beebe has studied this in great depth, finding that infants at 4 months old who later develop disorganized attachment patterns typically have caregivers who struggle to allow themselves to coordinate with the infant's emotional distress, likely relating to their own difficulties, making contact with and bearing difficult emotional experience. And essentially, this leaves the baby alone in these sort of raw, unintegrated fragments of emotional and sensory experience. And so we know that this is both predictive of later disorganized attachments, but also of psychopathology more broadly. And we've already heard the ways in which this also comes to bear in the clinical encounter within therapeutic relationships, that therapists who are perceived or rated as more cut off, as disaffiliative, are likely to achieve poorer clinical outcomes than those who are attuned, responsive, engaged with empathic resonance within the relationship. And so theorists have distinguished between this notion of feeling with versus feeling for, which perhaps is something of the, and I think this has been referenced already, a sort of distinction between a sort of affective representation versus a cognitive representation. Also might be understood in terms of sort of empathy versus sympathy. And yet a kind of balanced experience of this contributes to self-other differentiation right from our earliest experiences. So it is this gradual experience of sort of separation that allows a capacity to experience oneself as a separate individual. Cognitive theorists have tried to operationalize the concept of empathy, with Batson identifying kind of 8 core components, which sort of range from kind of this more sort of intuitive experience to a more sort of cognitive representation capacity. So I'll talk a little bit about different theoretical orientations to empathy. I guess really lending toward the ways in which clinical change, in fact, clinically significant difficulties themselves are understood and formulated, and the ways in which this informs clinical technique. So in more relational models, we might think of empathy being leveraged as the vehicle for emotional representation, integration, and regulation, thus aiding in the development and enhancement of socio-emotional cognition and facilitating identity development over time, versus models in which empathy is more of a scaffold to discrete, explicit clinical techniques, aiding in cognitive restructuring and behavioural change, which itself enables greater flexibility and opportunities for new experience and relationships. And of course, there is a bit of an overlap between either. So starting with psychoanalytic theory, and this is a very, very vast area, so this will be a whistle-stop tour. And I would like to try and separate it into kind of three distinct concepts. Though of course, it's very much interrelated. So Freud coined the terms transference and countertransference, actually at a sort of close point in time to when empathy was sort of being talked about across different sort of disciplinary fields. So both sort of Freud and Klein were focused on the way in which empathy is experienced in the clinical encounter is something of a kind of identification of the emotional communication made from patient to therapist, a source of meaningful information that needs to be carefully assessed, understood, and gently returned back to facilitate insight and integration. It also is understood as a means of the clinician reaching the patient. So Jung talked about the clinical encounter as mutually transformative in the sense that in order for the clinician to impact the patient, the clinician needs to be willing to be themselves impacted. Whereas Kohut, who focused more on working with narcissism, understood transference as early unmet object needs, such that empathy became a vehicle for meeting those needs within the clinical encounter. And then meanwhile, empathy can be understood as a means of establishing the capacity for thought itself and establishing a separate sense of self in which these kind of raw, emotional, somatosensory experiences that we are born into in infancy can be almost transduced into an experience that can be conceptualized and a concept that can be spoken to in declarative language. So this really is drawn from Bion's theory of thinking, with this sort of move from pre-conceptualizations, these raw experiences, to conceptualizations, to concepts themselves, and this being the development of our thinking apparatus, which he called alpha function. And Winnicott spoke to the importance of this happening in a holding environment, in which the individual's true self is enabled to develop over time, but importantly, this being within a kind of good enough context. And this is such that the caregiver, whether parent or therapist, isn't expected to be perfectly attuned all the time. And in fact, if anything, there needs to be a space for necessary frustration such that an experience of separateness can come to emerge in a way that is developmentally appropriate and manageable. And together, if all of this goes well, we begin to develop an experience of intersubjectivity. So this is really, once we have experienced ourselves as recognized in the world, our own internal experience making sense, such that there is a balance between cognitive and affective elements of experience, we start to be able to recognize others as having minds that represent us more or less accurately, more or less. And this capacity for this mutual recognition allows for what we call the intersubjective third, that is being able to see ourselves really from the outside, others from the inside, enabling a level of kind of cognitive flexibility, which of course is essential to then deriving kind of new solution experience in the world, but for social learning, really. Next, I'll speak a little bit about Rogerian therapies. This is person-centered therapy. So Carl Rogers, who was the founder of humanistic psychology, developed this on the hypothesis that certain relational conditions are necessary and sufficient to facilitate positive change, drawing on empathy as a core therapeutic process. And Rogers' thinking was kind of premised on the notion that emotional distress is born from a disharmony between an individual's actual self, their lived condition, and their ideal self. So it's not that dissimilar. It shares some similarities with Winnicottian thinking and also Jungian thought that the psyche is sort of purposive in nature, that actually distress can emerge when we are not kind of living up to our full potential. So he spoke to these kind of three principles of empathy, congruence, and unconditional positive regard within the therapeutic relationship. And as-if empathy, which again is empathy that allows a little bit of a gap, that whilst the person is seen accurately, they are seen accurately by another mind, which enables the development of a true self-experience. And so this being really essential to self-other differentiation. And he has this quote, that if I say that I accept you, but know nothing of you, this is a shallow acceptance indeed, and you realize that it may change if I actually come to know you. But if I understand you empathically, see you and what you are feeling and doing from your point of view, enter your private world and see it as it appears to you, and still accept you, then this is safety indeed. So empathy in cognitive behavioural therapy really has been closely operationalised in order to allow for a kind of measurement. It's a very dense model. In order to allow for a measurement of the constituent, or what we think the constituent parts of empathy to be. So as we know, Beck has sort of developed cognitive behavioural theory out of the cognitive triads, this notion of self, other perception, past experience and future expectation, getting people caught in these maintenance cycles that we are able to formulate and support individuals to find a way out of. So empathy here is seen to be core for formulation and treatment planning. Beck stated that by trying on the patient's negative attitudes and cognitions, the empathic therapist is better able to develop the formulation and begin to identify exits or antidotes. And we know that when this goes well, that it strengthens adherence to change techniques and within and between session practice. It facilitates cognitive restructuring, enhances motivation. And increasingly, empathic validation has been seen as a core technique within the CBT field. And this is across kind of pure CBT as well as third wave models. So the declarative procedural reflective model really separates out the kind of reflective, semantic and procedural components to empathic practice through the vehicles of the person of the therapist and the formulation itself, in which the individual is able to recognize their condition and see it from a different perspective. So perhaps facilitating something the third position, if we were to put it in analytic terms. I do want to say a little bit about empathy across areas of difference, recognising that I think this could be a talk in itself. And as I was writing this, I was thinking about the kind of developments and unfortunately the regressions in social consciousness that we've seen over the past 5 years or so. But I think together they really mandate this anti-racist responsibility to patients and systems and communities to explore aspects of racial consciousness, foster intercultural empathy and mind gaps in understanding. And there has been substantial work recently across different therapeutic models in addressing these in clinical thinking, which perhaps belay something of a kind of mind blindness to the experience of others who may occupy different positions or have very different experiences of being in itself. And I'm thinking there about neurodivergence. But as you know, as well, we might think about issues of sort of cultural difference, intergenerational trauma. And we know that the more culturally competent people are in therapeutic practice, the better the clinical outcomes, perhaps unsurprisingly. Similarly, there's been thinking done in this where there are issues of sexual and gender minority, that there's something in listening to experiences of identity where people have felt really very alienated from others and from themselves. Supporting self-acceptance and identity expression with congruence and genuineness, as well as an empathic attendance to how people's experiences of alienation, discrimination may manifest within a therapeutic relationship to be worked through. And finally, thinking about the double empathy problem in work with neurodivergent patients, recognizing that misunderstandings may indeed be reciprocal. It is not just those who are neurodivergent who may misunderstand others, but actually, given that their experience, perhaps at a cognitive perceptual level, is different, we may need to make efforts to kind of understand, to represent what their experience of themselves in the world is. Towards then addressing iatrogenic social camouflage. So we know that social camouflage, often employed by individuals with autism, is inversely proportionate to well-being. And so there's something about, again, thinking about those principles of congruence and acceptance, of allowing the true self to emerge in a safe relationship. And finally, more of a sort of pragmatic empathy, supporting reasonable adjustments to aid engagement, both in the therapeutic work, but also adjustment outside of the clinical space. So we've spoken a bit about this already around how empathic practice influences outcomes. So we know that across models, therapist empathy and the strength of the therapeutic alliance is predictive of change. So this has been evidenced in recent meta-analyses for over 6,000 patients. That it's a moderately strong predictor of therapy outcomes. And this is indeed when we control for factors such as, for instance, homework adherence. And Anderson has expanded this concept, looking at not just empathy, but what's termed facilitative interpersonal skills in general. So things like verbal fluency, emotional expressivity, persuasiveness, hopefulness, warmth, and the alliance bond capacity, which I would argue links to this notion I'll go on to talk about of facilitating epistemic trust, that is the trust in socially derived knowledge, through building a sense that the clinician, the subject is themselves trustworthy and a trustworthy source of kind of personally relevant knowledge. What do I mean by this? So I want to touch on the notion of mentalization, of which empathy is a really core construct. Mentalization is made up of affect consciousness, psychological mindedness, mindfulness, that is attendance to attending to the present moment of experience in ourselves and others, and empathy. And it operates on these 4 poles, so self, other, cognitive, affective, internal, external, and automatic and controlled. And that's to say that, maybe as a clinician, just thinking about previous conversations, we may need really to attend empathically to ourselves as much as the patient. So there needs to be balance. When we're mentalizing, it's a bit like walking. We're holding balance between cognitive and affective components and self and other and internal and external. And what this does is it allows a sort of shifting between first-person perspectives, that is I mode, I feel bad because, second-person perspectives, you see that I feel bad because, and third-person perspectives, we see together why I feel bad. And this is the development of the capacity for mutual recognition, but first it requires our mind to be accurately represented in the mind of the other. And it's through this that we come to build epistemic trust and that channels for social learning are opened. So to put this a bit differently, when we have accurate empathy and recognition, we might say, I recognize the version of me that you seem to be seeing. We see each other together. And this meeting of minds enables a shared interpersonal awareness. And this has been kind of termed jointly seeing to it or just it. And I found myself smiling putting these slides together because on the one hand, you have the CBT declarative, procedural, reflective model, and then you've got just it. So this allows a level of flexibility to enable new perspectives, and particularly this notion of social collaboration and learning. So how does this then work in clinical practice? How does it apply within different psychological therapies, but also more generally in clinical practice, what we might see, say, in a GP surgery? So when our mind is represented accurately by the other, there is this process of mutual recognition that enables we mode to be activated. Dialogue then acquires properties of ostension, and what I mean by that is ostension is sort of directed attention. So as we talk about ostensive cues, and that might be gesture, it might be tone of voice, and it might be a kind of empathic facial expression that speaks to something of, I see this is what is important to you, and actually this is the important bit that I'm preparing the other's mind. This is the important bit that I'm about to deliver to you. So this encourages a state of attuned listening. Within this, epistemic vigilance is lowered. The individual is more ready to attend to and assimilate shared knowledge. And thus we have the sort of epistemic channels begin to open. That ordinarily, for good evolutionary reasons, as Sarah was referring to, we have a level of epistemic vigilance. And it's only through experiencing the other as experiencing us accurately, and also then ostensively cueing to important information that we may be about to receive, that we would kind of put our trust in information that they're about to impart to us. So to summarize, really we're thinking about the way in which empathy facilitates both a kind of accurate representation of our own experience, that we can see our experience crystallize when it is represented accurately in the mind of another. But that in itself allows for an intersubjective experience. We see this together. And then that then lends to epistemic trust. That is a trust in the information that someone else has to offer being relevant and meaningful to us as an individual, thus facilitating social learning. And regardless of psychological model, this is a sort of a necessary component. It's a fundamental principle in which all therapies sit. And we can support this through specific models of supervision that tend toward building empathic resonance, addressing ruptures within the therapeutic relationship, or really refining the therapist's own reflective capacity towards being able to attend to the emotional material in the room. So I would like to summarize with a quote, and I guess it being something of an acknowledgement of the kind of health warning that this work comes with, that Sarah was referencing in terms of burnout. But in any psychological treatment, the doctor is bound to influence the patient, but this influence can only take place if the patient has a reciprocal influence on the doctor. When the doctor wears their personality like a coat of armour, they have no effect. They are only effective when they themselves are affected. Only the wounded clinician heals. And I think this speaks to something of the way that empathy involves pain. And to an extent, we must bear this and maintain our capacity to think, to integrate thinking and feeling, to hold balance, in order that we can work meaningfully with the material that comes to us. But this also comes with a necessary condition of separateness, that we are not overwhelmed by the material, and that at times an empathic response may mean standing separately to the patient. So it continues to be a very complex discussion. Yes, I would welcome any questions. Thank you.